I agree with all those studies, and there are some important negative trials that were presented at ESMO too this year, and we won't go into detail. But I thought we had escaped the perioperative data, but I too was impressed with the cameral data, and just as Dr. Rosenberg said, it was a phase 2 study looking at perioperative or neoadjuvant immune therapy combined with chemotherapy. And so, yet again, we have another phase 2 trial showing that neoadjuvant chemoimmunotherapy can increase pathologic response rates and it can improve overall survival. And so, I think as a field, we really need a randomized phase 3 trial that can compare neoadjuvant chemoimmunotherapy versus immunotherapy alone. It's hard to ignore this data. And so, John, do you use perioperative chemoimmunotherapy? If so, is this something you offer to all of your patients with locally advanced disease, or are you more selective about it?
That's a good question. I think first comment would be it was interesting that I think the complete response rate was something on the order of 25%, which is almost exactly the same as the lung data. I always say like the lung cancer guys seem like a step ahead of us. It seems like often, whether it comes to biomarkers or chemoimmune therapy neoadjuvantly. To answer your question though, I do use it in certain circumstances. And again, it's not standard of care, but for patients who will have um, kind of the borderline resectable, where yes, it's resectable, but this is going to be huge functional morbidity. I will certainly consider it in those patients where it might allow for a smoother, less morbid surgery. And then other times when you're on the borderline of can we truly perform definitive treatment one way or the other, this can be a good, I think, selective process. But for a stage 3 patient, for example, I'm not routinely giving chemoimmune therapy for anyone like that. We're really talking the kind of the most advanced, in quotes, resectable patients I've been doing it for. But it might be, and I agree, we need more data. We need a phase 3 study because maybe it is right for a lot of patients.
And Dr. Rosenberg, you've published some really excellent data about induction chemoimmune therapy. And so, what are your thoughts about this?
Yeah, thanks for that. And we our study looked at induction chemo with carboplatin paclitaxel along with nivolumab, a PD-1 inhibitor, not for the resectable patient, but for the non-surgical patient, the patients with chemoradiation, definitive chemoradiation-based treatment plans. And we did find with chemoimmunotherapy quite impressive responses. The objective response rate 86%, the deep response rate actually 54%. So we see with that regimen, very few patients that progress. And we also in that study adapted treatment based on the response. So the deep responders had a slightly lower dose in radiation from 70 to 66 gray and also had a smaller volume. So the elective radiation part was actually eliminated in the responders. And still that group that responded and got de-intensified treatment actually did similarly, if not even numerically, a little bit better than the non-responders that got full dose treatment. So, I think the takeaway for me in that setting is that neoadjuvant or induction chemoimmunotherapy should be explored not only in the resectable patients, but also the non-resectable patients. That we should continue to be studying immunotherapy, particularly in the biomarker enriched population with chemoimmunotherapy. I think we need to continue to explore that in the context of clinical trials.